They don't participate. Correct.
Good morning, all. Good morning, all. It gives us immense pleasure to welcome you all in this workshop. The theme of this workshop is Health Technology Assessment in Public Health, New Dimension. This is the first workshop organized by Resource Center HTA in collaboration with School of Public Health AIIMS Jodhpur and Indian Institute of Public Health Gandhinagar. On behalf of Resource Center HTA, we would like to express a warm welcome to all the participants, esteemed faculty members and resource persons who are joining this workshop from the different part of our nation. Now, I would like to invite Director AIIMS Jodhpur, Dr. Sanjeev Mishra, sir, to inaugurate and announce the workshop. Sir.
Thank you. Good morning, everyone. Professor Kuldeep Singh, Dean Academics, AIIMS Jodhpur, Dr. Pankaj Bharadwaj, Dr. Vibha Joshi, Professor Deepak Saxena from the Indian Institute of Public Health, Gandhinagar, and all the esteemed speakers and delegates. On behalf of the All India Institute of Medical Sciences, Jodhpur, it's a matter of great privilege to host this meeting on health technology assessment in public health, the new dimension. AIIMS Jodhpur is designated as a Center for Health Technology Assessment Resource Center. And we all know that in these times, technology interventions, whatever we say, all interventions are considered as a part of their technology also, has been extremely important. Whether we look at devices, we look at interventions for the public, we look at vaccines, everything gets covered in this. And I'm sure that if we talk about this, we disseminate information about health technology assessment, more and more people, that becomes extremely important, because what is the social impact of the health technology? What is the economic impact? What is the impact in terms of diseases, management, etc.? So everything does come under that. The School of Public Health at AIIMS Jodhpur has been collaborating with the Indian Institute of Public Health, Gandhinagar. And here at AIIMS Jodhpur, it's a very active faculty, which is the School of Public Health. And Professor Kuldeep Singh, Dr. Pratibha Singh, and all the other, and Pankaj, and everybody else who is associated with the health technology assessment here. I'm sure with the help of the faculty for this conference from Gandhinagar, from PGI Chandigarh, definitely this meeting will be good and people will benefit by it. And it's again on behalf of AIIMS. Welcome all of you, and really look forward to the deliberations and discussions that would be in this meeting. And I hand it back to the organizers to take charge and take things forward. Thank you so much.
Thank you, sir, for your kind words. This workshop would have not been possible without your support. Thank you, sir. Now I request Dean Academics, Dr. Kuldeep Singh, sir, PI Resource Center Health Technology Assessment, to introduce our center and brief the objectives of workshop. He is also professor and head of Department of Pediatrics with a super specialization in medical genetics. Sir, please.
So good morning, everyone. Thank you, Dr. Deva. Our director, Professor Sanjeev Mishra, coordinator of the School of Public Health, Dr. Pankaj Bharadwaj, all the esteemed speakers on this workshop. On behalf of AIIMS Jodhpur, I welcome you all. Health technology assessment is going to give a new dimension to the public health, and that is the purpose of this workshop. As we know that the health technology assessment refers to the systematic evaluation of the properties, effects, or impacts of the health technology. And basically, it is a multidisciplinary process to evaluate the social, economic, organizational, and ethical issues of the health intervention. This health intervention can be in any form. It can be medicine, it can be vaccine, it can be use of any device or new technology or new intervention which is related to any field of the medicine, whether it is in the hospital or outside the hospital or in the public. So the most important emphasis of this workshop will be on the public health. How the public health can utilize the health technology assessment. At AIIMS Jodhpur, this has been made the resource hub from the Health Technology Assessment of India by DHR in 2019 December. Since then, we are working with the state government and we are taking ideas from the various stakeholders, not only from the institute, but as well as from the public at large and also from the state government. Dr. Rafiq Ahmed is the nodal officer from the state health agency. He is also in a close link with our institute at the health technology assessment hub. So we are collaborating with the state government to find out certain areas or intervention areas which can be subjected to the health technology assessment to improve the health and ultimately to lead to the universal health coverage to whole of the population. So mission of this is to prioritize the needs of the healthcare. And as we know that the universal health coverage with the post-COVID and COVID, it has given a impetus to the healthcare technology. And we are now talking about many of the aspects of the health technology. It also aims to provide the universal health coverage along with the minimizing the out-of-pocket expenses. And vision of this institute as the center is a systematic evaluation with the main purpose to inform the policy making for the technology in the healthcare. So for last 1 year, we are doing many activities, that is promote assessment of the new and existing technology, sensitize the health agencies about the health technology assessment, provide technical support for the STA, prepare online database to do a systematic reviews and analysis of the topic which are assigned to our center, and also to collaborate with the state government toward the finding out the solutions, the cost benefit and the cost effectiveness, as well as the quality of life improvement of various interventions. So there are many resource centers throughout the country, and ours in the Rajasthan is one. And today's workshop objective is to deal with all the aspects of the health technology which can be applied to the public health. So we have a esteemed speaker, Dr. Pankaj Bharadwaj, who is additional professor and coordinator of School of Public Health, and he is running a very successful Masters in Public Health program at AIIMS Jodhpur. We also like to mention about Dr. Deepak Saxena, who is a professor of Indian Institute of Public Health, Gandhinagar. Along with him, Dr. Komal Shah, she is assistant professor. Dr. Sumail Shah, who is associate professor. From PGI Chandigarh, we have Dr. Shankar Prinja, who is one of the most leading expert in the health technology assessment. So he will be joining us today. Along with him, Dr. Gaurav Jani will be speaking on some of the aspects of the health technology assessment. He is a research officer and he will be dealing about the disability assessment life years. Also, we have Apurv Kumar Pandya, who is an economic evaluation expert, specialist from IIPH Gandhinagar. From the state, we welcome Dr. Rafiq. And from AIIMS Jodhpur, we have Dr. Nitin Joshi and Dr. Biva Joshi. And along with Dr. Jain is also here in our School of Public Health. We are being assisted with Ms. Deepika Joshi. So in all we hope this workshop will be giving enlightenment to the use of the health technology in the public health. And I wish all the success for this workshop. And we'll be ready to any questions in collaboration or any ideas are most welcome during this workshop. Thank you.
Thank you, sir, for your kind words. Now, I would request Dr. Pankaj Bharadwaj, Vice Dean Research, Additional Professor in Community and Family Medicine, and Coordinator of School of Public Health, AIIMS Jodhpur.
Thank you. Okay, thank you, Vibha. So I think my screen is visible or not? Share here. Okay, sir. Sir, share हुआ मेरी slides. Share. I'm awake. And is it in the full mode?
Yes, sir. Yes, sir.
Huh?
Yes, sir.
Okay, thank you so much. And on behalf of All India Institute of Medical Sciences, Jodhpur, as well as from Resource Center, I welcome you here. And we've already heard Professor Kuldeep Singh sir about the objectives of this current workshop. So, friends, I'll be taking you quickly to the overview and scope of health technology assessment, which we are doing here, and what are the overview of this HTA in public health. But before I start, it has already been mentioned by the Dean sir about the kind of resource centers and technical partners which have been given by Ministry of Health and Family Welfare as well as Government of India. And as you all know that we have these 8 established centers or hubs which are already working in the state, in different states across country. And would like to humbly be an advocate over here that we are the new center, and out of these new centers, AIIMS Jodhpur has started taking initiatives to contribute in the areas of health technology assessment. So when it comes to the health technology assessment, it is about, if there are not many definitions and not many ideas which have been mentioned, but to say about health technology assessment, it is a kind of a multidisciplinary approach where people from across specialities, they sit together, they analyze the health technology, and the overall outcome or overall output is to have some evidence-based decision-making process, and overall idea or objective is to benefit the health care. So if you look at the slide, which we have tried to mention over here, that this multidisciplinary, it ranges from doctors, physicians, nurses, pathologists, lawyers, public health people, and even patients, community representatives, pharmacists, pharmacologists. There are a huge group of people who sit together to do a health technology assessment. So if you look at this process, and I always call it as a kind of a system approach, and when there is a system, there is always input, some process, and some output. So if I say input, so input would be in form of some information or data. So this information or data can be from any clinical part kind of thing, social, economic, or organizational or ethical thing. And this health technology can be in form of anything. It may range from medicines, it can be in terms of vaccines, medical devices, or clinical interventions. So what is this whole process about? I think for the next 2 hours or so today and tomorrow, we will be discussing about the entire process of health technology assessment. So what is that process? It's a systematic, transparent, unbiased, robust analysis, which involve systematic reviews, which involve economic evaluations, which involve meta-analysis. And I think many of our speakers are going to speak on this whole process. But at the end of the entire process, the most important output which we are going to get is a kind of results which will help in formulating and supporting effective health policies. And overall objective would definitely be to have an improved patient health outcomes. So if somebody asks me to summarize that what health technology assessment is all about, I will say it's a tool to develop an evidence which will help in decision making for healthcare benefits. So when it comes to the purpose of health technology assessment, I would like to mention over here that it is, as the Government of India mandate, as Professor Singh has already mentioned, that it's about the universal health coverage agenda. So when it's about universal health coverage, we know the overall objective of universal health coverage is that everybody in the country should have an access to affordable health care. But at the same time, it is also to ensure that whatever money is spent over these services, we should have the optimal utilization of that. So how to ensure that the optimal utilization of the resources is there with an amount of every rupee spent on that. So it's a challenge. It's a challenge for government or the policymakers to understand that we need to ensure that whatever we are doing, it is for the betterment of health as well as with the optimal utilization. And at the same time, we should also reduce catastrophic oops or out-of-pocket expenditure to ensure affordable access to healthcare. So health technology assessment agrees to that, or it addresses that important issue of optimization of resource allocation in health. So if you ask me what are the objectives of health technology assessment, so the objectives of health technology assessment will be to maximize health, which is expanding coverage without compromising the quality of healthcare services, reducing OOPs and reducing inequality. So I think the kind of thing which we have mentioned on the right side, which is about efficacy, effectiveness, value for money, ethical considerations, budget. So this overall help us to reach to that overall objective of reducing inequalities. So how we do HTA procedure, and I think for the next 2 hours and so, we will be discussing about these. You can see over here if there are 2 choices to choose from, if we have 2 plans or 2 procedures, these are the criteria on which we are going to evaluate the technology. And that includes or that involves efficacy and effectiveness, value for money, social, legal, ethical consideration, equity, budget impact. So all of these would be there. So if you say about the 2 choices, choice A and choice B, so these choices would be evaluated through HTA procedures. So I think this is that entire model which we are going to discuss today from the next speaker, Dr. Deepak Saxena and his team from Indian Institute of Public Health, Gandhinagar, where they'll be taking us to this entire process of health technology assessment, which is totally based on what we say a very specific question, which is about PICO or population, intervention, comparison, and then we say about time framing and setting of interest. So the entire process today we'll be discussing about this whole model of HTA or health technology assessment. But before I hand it over to my next speakers, I would just like to mention about the basic orientation of assessments, because there is always a question whether health technology assessment means just when we are assessing the technology in terms of some kind of equipments only, then it is not so. Actually, health technology assessment have 3 basic orientations, and it can be a technology oriented assessment. My colleague from SPH Jodhpur, Nitin, would be mentioning tomorrow about how we did that e-Upakaran assessment. E-Upakaran is a system of online maintenance and management of equipments. And so this is a kind of a technology-oriented assessment. It can also be in terms of problem-oriented assessment. Like, for example, the Resource Center HTA AIIMS Jodhpur, they are trying to develop a system to have a pre-referral delivery of gentamicin ANM to manage neonatal sepsis assessment. We already know that this is already there by Government of India. So would like to know that whether this is going to be a kind of efficacious or based on the type of quality of life index and all. So second one is problem oriented assessment. So if you ask us the third basic orientation of assessment, it will be project oriented assessment. For example, if a hospital is having installment of a robotic surgery units, so is it going to be beneficial to the patients at large and to the system at large? So we need to see it. Then also we can apply health technology assessment. So basically, health technology assessment uses these 3 orientations. So sometimes we are using only one of that. For example, we are using technology oriented assessment only, but sometimes all the 3 are clubbed together in our assessment process. So now the question arises, do we do HTA in an entire domains, and how many domains of HTA do we know about? So if we say about health technology assessment, usually there are 9 domains of health technology assessment. And if you look at the left side where there are 4 domains, they talk about problem, description of technical characteristics, safety assessments, and clinical effectiveness. But these are not just the 4 domains. Apart from that, there are 5 more domains, and these are economic evaluation, which is cost effectiveness and utility. And I believe my colleague from Indian Institute of Public Health, Gandhinagar, will be taking us to this entire process of economic evaluation. There are domains in terms of ethical analysis, organizational aspects, social and legal aspects also. So we say if there is a full HTA report, then it involves all the 9 domains. So the full HTA assessment will have all these 9 domains together. But as I mentioned it earlier, HTA is not that new, but it's not that old also. And we are evolving in the process of HTA. So usually there is a rapid review which is covering first 4 domains. And these first domains are these which are transferable from one country to another. So a mini HTA questionnaire, usually we have seen in many of the studies that they are not doing the full HTA assessments, Rather, they are using this mini HTA questionnaire, and this mini HTA questionnaire is using all these four domains, and these four domains I'll again spell. These are problem statement, current use of technology, the technical characteristics, safety assessment, and clinical effectiveness. So I hope from now the speakers who are going to be with us, they'll be taking us to the journey of health technology assessment. And I think and I hope that the entire 2 days would be beneficial to all of us to understand the nitty-gritties of health technology assessment process. Thanks once again for joining, and I'll hand it over to Vibha to take us to the next session. Thank you so much.
Thank you, sir, for giving the overview and scope of HTA to our participants. Now I request Dr. Deepak Saxena, sir, professor from IITH Gandhinagar, Indian Institute of Public Health, Gandhinagar. He will provide us the overview of systematic review and meta, along with Dr. Komal Shah, the systematic review and meta-analysis in HTA. Over to you, sir.
Hi, good morning, Weber. Thank you. Can you just give me the rights to share my screen? In present, when I'm not able to share my screen.
Yes, sir. Just we are.
Yeah. Thank you.
Dr. Deepak Saxena, right click. Right click. Change the role. Make presenter. Okay.
Sir, I think now you'll be able to present your slides.
Yeah. And I thank you for that. Sorry. I'm not sure if my screen is visible to you or not. Is it visible now? Yeah.
Yes, sir. It is visible.
Yeah. Thank you very much, and thanks, Dr. Pankaj, for this introductory remarks. And at the onset, I'll thank Director Sir from All India Institute of Medical Sciences, Jodhpur, Dean Sir Dr. Kuldeep Sir for inviting us to be a part. So I'll quickly talk about why it is important for health technology assessment to actually incorporate one of the important components that is none other than systematic reviews. And by the end of this session, you'll be able to understand what is a systematic review, how to undertake a good systematic review. And maybe I'll spend 2 slides on a small case study. It's an anecdote which we did at IITH Gandhinagar on how systematic reviews can quickly be developed. I'm sure all of you must be actually talking about COVID, and we are in the midst of the second wave. So COVID is not the only pandemic which as an academicians we all are facing, but there is also a pandemic of huge amount of publications. And there are certain research articles which say that 46 RCTs are enrolled almost daily. There are 1,000 new Medline articles and 6,000 biomedical articles. I'm not sure if you have got an access to Retraction Watch. Maybe you'll be happy to look at those articles which are not only published, but there is also the articles which are now getting retracted. The global evidence suggests that the retraction should be of the order of 1 to 4 per 1,000 published article, but it has already crossed 10 to 20 published article, 10 to 20 retractions per 1,000 published articles. Annually, beyond COVID also, we had huge amount of articles which are always submitted, which are published. There are n number of journals, and majority of these articles which are published in health journals or public health journals and medical journals are poorly done. They have insufficient relevant information that can be used by the clinician. But still the debate goes on whether tocilizumab should be given only to hospitalized patient or whether remdesivir should be given on home basis and so on and so forth. So too much of information is available. There is too little of time, and sometimes the high quality of information is not at all available. And so what's the solution then that's left with the policy planners and the program managers? It is nothing but what we look for more evidences, and then finally we go to what is known as expert advice. And majority of time, expert advices are conflicting, they lag behind the evidence, and they are inconsistent. And there was a wonderful article which published which says that self-rated expertise is inversely proportional to methodological rigor. That means that you have to do something else beyond expert evidence. And then comes what is known as review article. So, the second step of generating evidence is none other than review article. In review article, it's a generic term. What we do, we read articles and we try to synthesize the results and conclusion of at least 2 or more than 2 publications on similar topic. But reviews can be biased. The one bias is the studies which are included in our review, and equally true is the studies which are not included in our review. And last but not the least, the bias which arises because the way in which this particular review has been done. And therefore, the only solution that is left with us is none other than to look for something which is more robust. And that's where comes the domain of what is known as a systematic review. So what is a systematic review? Systematic review, it's a systematic process of locating, evaluating, and synthesizing the evidence from all possible available literature using a strict scientific design or scientific guideline. And therefore, a systematic review is systematic because it identifies the literature. It is explicit because it is a clear statement of objectives, methods, and materiology, and it's reproducible. So each some systematic review is done by Pankaj and his group at AIIMS Jodhpur. And if I follow the same process, then there is a possibility that if the same methodology has been adopted, then the results actually can be reproducible. So that is what is important when we talk about systematic review. So systematic is most important because it minimizes the bias. It minimizes the bias in which the review is actually carried out. And therefore, it is important that for any person who wants to venture in research or also for health technology assessment, he should understand the final nuances of how to conduct a systematic review. It's simple, yet it is very difficult because there are 3 important stages of conducting a systematic review. Stage 1, you should plan a review. Stage 2, you should know how to conduct that review. And stage 3, how should you really actually synthesize the evidence? You report it and you disseminate it. So me and my colleague, Dr. Komal, will talk to you about this in detail in next maybe 30 minutes. So the first stage for doing a systematic review is developing a review protocol. That actually talks about you should have a clear-cut review question. Now, Dr. Pankaj has already mentioned to it, but whenever you want to design a review question, you should break it down into simple components. Say for a very common acronym that we use is PICOT. What types of participants, what types of intervention you are looking for? Are you looking for any comparison? What type of outcomes are you looking for? And what should be the actual time frame? So once the review question is being formulated, you start searching and selecting studies. Now, one thing should be very clear, systematic review is a team effort. You need to have a team of at least 2, or in other words, you must have like-minded persons who should be able to spend quality time to actually go for the quality of assessment. So you start making up team. Once you start making up team, you start selecting what is known as developing a search strategy. Now this search strategy should be pretty comprehensive, pretty objective, and pretty reproducible. It should have very explicit inclusion and exclusion criteria because you are doing a systematic review which is actually reproducible. You can include a duration, whether you want to look for last 10 years or 20 years. You can actually decide for the type of journal, and probably this is the most time consuming and challenging task. Once you have decided your inclusion, exclusion criteria and your methodology, you start looking for the data sources. Now, it depends upon the researcher, whether he wants to go for published articles, which are only in PubMed or Embase, or he also wants to go for gray literature, or he also wants to go for checking and rechecking the reference list or cross-referencing. Even some of the systematic reviews are on the data that has been published as a part of various trials. So once you have actually decided for your method, you have actually decided your inclusion criteria, exclusion criteria, you start looking for what is known as quality assessment. And my colleague, Dr. Komal, will talk about certain tools which can assist you in designing or in deciding the quality of the studies that actually should be done. And there comes the importance of having at least 2 independent reviewers because you want to make it more robust. And once you have, you have started, taking out or extracting the information from various studies, you should look for the validity. There are ready-made scales and checklists which are available for ascertaining the validity of your systematic reviews, and then you start extracting data. Now, extracting data is the most important part of picking out information from those systematic reviews. You can collect the data in simple Excel sheets. There are softwares which are available. Revnan is a very famous software which actually can assist you for extracting the information. You should collect the information on methods, participants, intervention, outcomes, and most importantly, the time duration for which you have been doing. And finally, you go for what is known as synthesis of data. My colleague will talk a lot about meta-analysis and also methods by which you can synthesize the data. But it is important that once you undertake a systematic review, you should have that motivation to complete it, and because it takes a lot amount of time. A systematic review, if at all done properly, appropriately, it can reduce the subjectivity. It can assist you in developing or refining or even testing your hypothesis. And it increases your statistical power. It also identifies the heterogeneity in effects. So most importantly, if a systematic review is done appropriately, it can assist to add more additional evidences to the existing body of literature. You can calculate sample size for further studies. You can identify the data. For a program manager and a policy planner, it is very important that it can suggest the directions of the interventions that needs to be done. But as all study design, systematic reviews also comes up with certain limitation. One of the limitation is the reporting bias, because largely systematic review is based on the published articles, and that itself can be a bias because we are picking up something which is actually published or either in gray form. The second comes up with what is known as publication bias, and the third is language bias, because in inclusion criteria, if at all I make a case that I want to undertake a systematic review, and I'll take under systematic review on let me say remdesivir, and I include all those articles which are published in last 2 years and published in English journals. The majority of the trials in recent time have been done in China and Spain, Brazil, where the articles would have been published in different languages, and that itself can lead to some amount of biases. So that comes up with language bias. So, systematic review or conducting systematic review is an art. It is something which depends on teamwork, and therefore, if at all you are thinking of undertaking a systematic review, you should have a large team. And I'm fortunate enough to have a big team, not only from AIIMS Gandhinagar, but many of our colleagues are partnering with colleagues from All India Institute of Medical Sciences, Jodhpur, Pankaj, Vibha. We have our good friend Dr. Jayakaran from Department of Pharmacology, where we make a big team and therefore we reduce the biases to a larger extent. Finally, I take 5 minutes for discussing with you on how systematic reviews can be developed even by single thought of idea. So last year, AIIMS Gandhinagar is almost 45 kilometers from Ahmedabad, and almost every day, few of our colleagues we pool car and we travel to AIIMS Gandhinagar. All of a sudden, we found one hoarding which said that Amul has come up with camel milk, and they say that camel milk is good for diabetes and it is largely better for diabetes management. So all those diabetes should actually start avoiding what is classically known as cow milk or other milks, and should start taking up what is known as camel milk. And the price that was quoted was 100 rupees per liter. So it was almost double what is the normal other milks that is actually available. So while going to Ahmedabad, while going to Gandhinagar from Ahmedabad, there was a discussion amongst our colleagues, and we said that is it really true, or is there any evidence? So we started thinking of undertaking a review, and a review was a gross term when we started looking at the existing body of evidences which actually suggested the impact of camel milk on diabetes. We were very excited because immediately we thought of coming up with a systematic review. You'll be surprised to know that there were only very few articles. We could not find more than 10 articles which actually were randomized control trials or some review which were actually done on impact, on measuring the impact of camel milk for reduction in diabetes risk or even diabetes. There were actually only one article which we could find. There were majority of the articles which actually suggested that the evidence of impact of camel milk on diabetes is not for diabetes 2. It is largely for diabetes 1, where there were few pilot studies. Unfortunately, 4 studies which got published from India were published by a single author. Majority of the RCTs that were done were underpowered. They were not having sample size which actually can detect the difference. So sometimes it is important that whatever you look, whatever you think, and whatever you come across, you should have that basic argument of debating that is the information that is made available is true or not. There comes the idea of undertaking a good systematic review. And if you look at the hierarchy of evidence, if you look at the evidence synthesis pyramid, systematic reviews and meta-analysis are at the top. And all of a sudden, if you are applying for any, all of a sudden, majority of the funders, they have started asking for, some evidence on your research hypothesis, and a lot amount of researchers are now presently undertaking what is known as systematic reviews. So please, if you are applying for any grant or if you are looking for any any publications, or if you are looking for any critical review, read more about systematic review. This is a small primer which we thought, and thank you very much. I'll be happy to any question, but I hand it over to Dr. Komal to take ahead the discussion from here. Over to you, Dr. Komal, and thanks again.
Thank you so much, sir. Thank you for your view on systematic review. I welcome Dr. Komal Shah from Indian Institute of Gandhinagar. She is an assistant professor there, and she has a lot of work on systematic reviews and meta-analysis. Welcome, ma'am.
Thank you very much. Myself, Dr. Komal Shah, and first of all, I would like to thank all the organizers for having me over here. And as Professor Saxena has set a stage for this systematic review and meta-analysis, I'll pick from where he left. Hope I'm audible to you all.
Yes, ma'am, you are audible.
Thank you. Yeah, I'll just share my slides. Yeah, hopefully it is visible, my slides.
Yes, ma'am.
Yeah, thank you. So I'll pick the things from where Professor Saxena has left. Actually, he has given us a wonderful overview about the systematic review and meta-analysis, especially the need of the things and why it is important to critically evaluate and weigh the evidences rather than going for a simple review. I'll just pick some of the things from his talk, like what is the basic difference between systematic review and meta-analysis. Now we have understood that general reviews, how they are different from systematic review. But there is also a difference between systematic review and meta-analysis. So essentially, the meta-analysis is a systematic review with a quantitative component extracted from the studies. So in systematic review, through strict inclusion-exclusion criteria, through strict study search strategies, we identify certain articles. And then we synthesize the evidences from those studies. It has got two components. First component is a qualitative component, and the second component is a quantitative component. In meta-analysis, we try to extract the quantitative components from those studies in the form of their results, and then we subject it to certain analysis. And then we derive a pooled or a cumulative effect. So this is the area from which meta-analysis differs than the systematic review. In systematic review, it could be combinations of qualitative and quantitative, both the things, but in meta-analysis, it is explicitly the quantitative analysis of the studies. So now just to brush up the things, what is the basic difference between descriptive, systematic and meta-analysis kind of studies? So they are on the three domains. The first domain is related to the literature search and data extraction. As Professor Saxena has already mentioned, in descriptive or a narrative or a scoping kind of review, it could be done by a single researcher. And hence the literature search and data extraction could be heavily biased. Whereas in case of systematic review and meta-analysis, it is a team that undertakes this entire process. So it is subjected to various levels of filters and discussion, deliberation, and consent. So in that case, there is a possibility that if there is a bias, that is subjected to a lot many opinions and a lot many judgments. And after that, only the study is included. So that adds a value to the study and that helps in improving the quality of the study. So in that way, systematic review and meta-analysis are different than rest of the reviews. The second is the strategies. Strategies in terms of search, strategies in terms of methodology, strategies in terms of the quality assessment. Everything is very well defined and standardized in systematic review and meta-analysis. Whereas in case of descriptive review, it is a reviewer's perspective. If I want to include certain studies, I might modify my strategies. I might modify my inclusion exclusion criteria, and I might not bother to list them in my publication. So that is a problem with descriptive review, and that introduces a bias in the system. So replication, or what you say, the reliability of the results is in a questionable form in case of descriptive review. Whereas in case of systematic review and meta-analysis, its guidelines are available. We will be discussing in the later half, and everybody who undertakes systematic review and meta-analysis, they need to follow those guidelines. There are checklists. Those checklists must be ticked, and that should be provided in their final manuscript or the articles that they are planning to publish. So let's introduce a transparency in the system. This increases the quality of the system or the analysis or the evidence that we are generating. So that is one more important difference. And the last one is conclusion. As we are not following any strict guidelines or any checklist or any predefined methodology in descriptive review, the opinions might be biased. As I think we have seen in our previous presentation, that I might choose certain study which I like, which only favors certain interventions in case of descriptive review. But whereas in case of systematic review and meta-analysis, I need to include all the studies, or I need to evaluate all the studies. And if I'm eliminating some studies, I need to have a proper justification for that. That adds a very good quality to the evidence that we are synthesizing. So my conclusion when I'm doing systematic review and meta-analysis are very less biased. And that is the basic difference between all this kind of studies. However, there is one more difference between systematic review and meta-analysis that I've shared earlier. Like in systematic review, we synthesize qualitative evidence, whereas in meta-analysis, quantitative part plays a big role. Moving ahead, why systematic review and meta-analysis are needed when we can just average out the studies. In meta-analysis, say for example, I have 10 studies. I also do the averaging of the study. I also undertake the cumulative assessment. That could be done by just simple averaging of the results. Why can't I have the mean of any particular variable from all those 10 studies? Why do I need to undertake such a huge analysis that we call a meta-analysis? Why not to go ahead with the simple strategies? So there is a difference between averaging of the studies and undertaking an entire meta-analysis. So first difference is that whenever we are averaging the studies, we give equal weightage to each and every study. We don't pay attention to the quality of the studies. Whereas in case of meta-analysis, the weightage is given to the studies which has got a greater sample size, which has got a greater events, and which has got a lower variance. So the study which have got a good quality methodology and relatively reliable findings, they will be given more weightage as compared to the study who are inferior in terms of quality. And this makes us different than the averaging, just plain averaging of the results. So in meta-analysis, yes, we are pulling out the results from individual studies. We are also doing averaging of the findings and coming up with the cumulative results. The only difference is that we are weighing the study as per their quality. And that makes it different than the averaging of the results. Then meta-analysis helps us to pay more attention to the randomized study also, so that it increases the power of the studies. Then it helps us to address the bias, pay attention to the quality of the study, pay attention to the heterogeneity of the study findings that we are synthesizing. So just to discuss those things in bit detail, like it helps us to identify the heterogeneity. Not only it gives us the estimation of the heterogeneity, it also helps us to identify the source from which study or from which area, from which population, from which methodology this heterogeneity is coming. So through meta-analysis, we can identify that thing. Then, as Professor Saxena has mentioned, it increases the statistical power, data gaps can be identified, future study sample size can be calculated. One more important factor with meta-analysis and systematic review, like you can calculate, you can reassess your cumulative impact through sensitivity and subgroup analysis. Say, for example, I have one intervention that is showing an effect in general population. But when I'm subgrouping that general population in terms of like patients with comorbid condition, patients in younger age, and then I came to know that patients in comorbid condition, patients who are having certain comorbid condition, this intervention is relatively more useful as compared to patient without comorbid condition. So meta-analysis help us out, or they provide us that kind of flexibility to undertake a subgroup and a sensitivity analysis. So whatever result, cumulative findings that we get, we cross-verify it, we double-check it through various sensitivity analysis as well. So that adds robustness to the evidence that we are deriving from the meta-analysis. So now this simple steps that we have previously discussed, I'll skip those things. Just the databases. Generally, we use the standard databases, which publishes the peer-reviewed article. In systematic review and meta-analysis, we generally do not take non-peer-reviewed articles like thesis and certain blogs or certain other things which has not been reviewed properly. Those things are eliminated because they are gray literature, we call it. Generally, they are the major source of bias because no concrete methodology has been followed in those kind of studies. So in systematic review and meta-analysis, we generally rely on the standard databases which publishes peer-reviewed articles. In the next step, through the database searches, whatever article we get, we first evaluate it through their abstract and titles. And then we prepare a pool of articles that should be subjected to the full text evaluation. If we find those articles to be really useful for meta-analysis and systematic review, there is the addition of one more step, that is a quality assessment. So through various scales, we evaluate the quality of those articles, and the articles who performs inferior on the scales of quality, we remove those articles. So in that way, we only take articles who are conducted through very good methodology, who reports, who do not hide anything, who reports everything in a very transparent manner. There are no data gaps, only those kind of articles who are subjected to a rigor of methodology. Only those articles are being taken up for meta-analysis and systematic review. Then for meta-analysis, we calculate a summary effect size. And for that, we extract the quantitative information like mean of certain variables, mean, standard deviation. If odds ratio is given, that information we are taking. If a frequency of any event is given. So those information from each and every article we extract in the form of electronic metrics. And then we subject it to the statistical analysis. After that analysis, we get our findings in terms of forest plot. And in the later half of this presentation, I'll discuss that, how do we do that. And then whatever cumulative results we get, we subject it to the sensitivity and subgroup analysis to further add quality to our findings. FICOT we have already discussed, so I'll skip this. Yeah. So if we are not following any strict guideline, or if our inclusion exclusion criteria are not in place, our quality assessment tools are not in place, after a meta-analysis, a very common term people are using, it's a key goal, garbage in, garbage out. We'll end up doing the same thing, which will give us the results which are not reliable and which are not reproducible. So it is extremely important to pay attention to your research question, your search strategy, the database that we are using, and the quality score. Without this, I think entire exercise will turn into a futile exercise, where our conclusion will remain non-reliable and non-reproducible. Yeah, these are some of the indicators that we should be taking up when we are preparing a matrix for our meta-analysis. However, I'll pay attention to the quantitative indicators only. So as I mentioned, if my outcome of interest is presented in a continuous scale, say for example, mean hemoglobin level. So from each and every article, I'll be extracting the information about the mean hemoglobin level. Now I need to take a variable that is giving me an idea about the variance also, how well my studies data is distributed. In that case, I need to take standard deviation from the studies as well. If my outcome of interest is expressed in terms of binary scale or binary variable, in that case, I'll be taking a number and percentage of any particular event. Then I'll subject it to the quality score. Now, we were discussing about the quality assessment in terms of meta-analysis. However, meta-analysis can be conducted for different research questions. Say, for example, I wanted to study a prevalence of hypertension in one particular group. So for that, I'll be extracting the information from different articles regarding the prevalence of hypertension, and then I'll be having a pooled hypertension prevalence effect. So for that kind of study, my quality assessment tool will be different. If I want to undertake meta-analysis of an RCT, which checks an efficacy of one particular drug on blood pressure level, in that case, my quality assessment tool will be different. If I am enrolling a study which are cross-sectional in nature or cohort, my quality assessment tool will be different. So the purpose of saying all these things was that the quality assessment tools, ample of quality assessment tools are available, which are globally acceptable. But which tool should be chosen, that entirely depends on the type of research study that we are undertaking. And based on that, I'll just show you the list of popular quality assessment tools that we generally use. So first and foremost, the Cochrane manual. The Cochrane manual has given us a wonderful information regarding how a meta-analysis should be conducted. It just it not only gives you the software, but it also helps you out with certain tutorials, and it is a guideline manual which everybody is following globally. In its chapter 8, the risk of bias assessment tool is given. So that is popularly being used. Then other scale is like a Gedard scale or an Oxford quality scoring system, that is also popularly being used. Grade system is also used. Then AHRQ tool is being used popularly, and then NOS, that is a Newcastle-Ottawa scale for non-randomized studies. So these are some of the scales that are being used. Just to go into a little bit of detailing how the scales are being used. So say, for example, I want to have meta-analysis of RCTs. So RCTs should have certain integral components, and based on those components, the quality of those studies are being assessed. So first components is like randomization. Then the next one is like a risk of selection bias, information bias, and confounding variables. So any RCT which has not followed the strict criteria of randomization, that might give us an not so accurate results. If there is a selection bias, if there is a gaps in the information, if we have not undertaken the influence of the confounding variables into consideration, I might end up getting an RCT which is falsely reporting something. So whenever I'm including any RCT in my study, I need to pay attention to all these indicators, and based on that, the quality of my study will be evaluated for meta-analysis. So JEDAL score takes care into this kind of indicators. This is just an overview how we should be scoring our studies. Based on certain questions, we should be giving numbers to our studies, and the cumulative score should be beyond the threshold. If it is not beyond the threshold, I should be removing that study from my meta-analysis. Like the first question that states that randomization was done or not. If it is done, I should be giving certain points or score to my study. Then the methods of randomization or random sequence generation was described appropriately or not. The study was double-blinded or not. The methods of double-blinded was described properly. If properly it was described, was it appropriate or not? So we need to answer all this question. Was there any dropout? Was there any withdrawal? And if these things are not mentioned in my studies, I'll keep on deducting the points from the overall score. And if it is mentioned, I'll keep on adding the things in the overall score. And if the overall score goes beyond 3, I'll be considering it for my study, meta-analysis. If it is not going beyond that, I think that is of poorer quality and I should remove that study from my analysis. Now, moving ahead, that as we are talking since morning, that systematic review meta-analysis, they are transparent methodologies to undertake any evidence synthesis. How these things adds to the transparency of these studies? It is because of this kind of registries. As all of you must be knowing that there are certain databases or certain registries where we need to register our systematic review and meta-analysis. And that makes this available in the public domain. Anybody who wants to conduct a systematic review and meta-analysis in the domain which you are currently working on, they'll have access to your protocol. So if there are any bias, if there are any counter opinions, if there are any contradiction, they can communicate with you, and there will be difference of opinion, and that adds to the quality of the study. So these are generally popularly known as international prospective registers of systematic review and meta-analysis, that is Prospero, and one more important registry is a Cochrane review. So I've provided the link over here. If any one of you is interested, you may go to this websites and check it. It is self-explanatory, and in Cochrane they gives you a tutorial also. So based on that tutorial, I think if you keep on following, you'll come to know that how you can register your protocol. But when you want to register your protocol, before that you need to have certain things in your hand. This site makes you understand that what kind of information you should be having before actually proceeding ahead with the registration. So this is about the Cochrane tool, and this is about a Prospero tool. Now the quality of systematic review and meta-analysis is improved because of certain guidelines and certain checklists. And popularly used checklists and guidelines are PRISM and MUSE statement. So once you follow this link, I think you will be guided to this checklist. This checklist asks certain questions and asks you to introspect and go back to your protocol and see whether you have included all this information or not. If you are missing certain things, they will let you know that this will severely hamper your quality of meta-analysis or systematic review. So this was an overview of PRISMA, and the previous one was MUSE guideline. Now in meta-analysis, frequently you will encounter these terms like heterogeneity and estimate effect. So what do these terms means? Before that, I'll just give you the list of the software that can be useful whenever we are undertaking meta-analysis. RevMed is very popularly used software and which is free. That is using a Cochrane Q statistics that gives you a result in the form of chi-square that gives you a p-value significance level. I-square is a heterogeneity indicator. So if your I-square is below 25%, it means that the studies that you have included in your meta-analysis, they are giving you a what you say, hint, which is pointing in the same direction, and your studies are following certain quality and they are of same methodological rigor. Then if it is more than 50%, it means that lot of heterogeneity is there. You need to undertake certain measures to reduce your heterogeneity. Beyond 75% I-square, it means that your heterogeneity is really high and you may give it a second thought to consider it for meta-analysis or not. Then for meta-analysis, there are two models that are being popularly used. First is a fixed effect model and the second one is a random effect model. Fixed effect model is generally used when the studies are having relatively low heterogeneity, whereas in case of high heterogeneity, random effect model is being used. Now, what this model means to us? Fixed effect model, as I've said, lesser heterogeneity, we use this model. It assumes that size of treatment effect is same across all studies. Whereas in case of random effect model, it assumes that size of effect is different among the study. A fixed effect model, it has got a narrow confidence interval because it is not having much heterogeneity, whereas in case of random effect, there is a broader confidence interval. Larger p-values are associated in case of random effect model, whereas in case of fixed effect model, smaller p-values are there. Then the final conclusion, it is being given to us in the form of summary effect size, effect estimates. And that we'll see in forest plot. Now your forest plots look like something like this. There are certain studies which are individually plotted and then there is a cumulative study that is plotted like this. Over here, I have given an example of one of my studies where I had 3 studies and I conducted a meta-analysis. So the square box or the rectangular box that is giving me an effect size of an individual study, whether it is favoring an intervention or whether it is opposing an intervention. And then the diamond or shape, it is giving me idea about the aggregated effect size. So as we have seen it in the previous slide, in meta-analysis, we are assessing something averaging out in terms of weight of individual study. As you can see, the third study, the square is relatively smaller and the horizontal line is relatively broader. The square, it is giving us an idea, the size of the square is giving us an idea about the weightage that we are giving to each study. So the bigger the square, higher the weightage. And the 95% confidence interval, it is being depicted with the horizontal line. So based on this 3 study, a cumulative effect is calculated and which is being depicted as a diamond, aggregated effect size. Over here, as you can see, the fixed effect and a random effect model, both are given. As you can see, the fixed effect and a random effect models are plotted in the same line. It means that the study is not having much heterogeneity and hence fixed effect and random effect model are giving you the similar results. So this was just an idea about the forest plot. One more important factor in meta-analysis is the publication bias. Certain journal editors, they prefer to publish something. There are smaller studies which find no place in certain journals, and those kind of bias are there. So meta-analysis pay attention to this bias, and it has got a statistical tool to assess this publication bias. Then this bias has got a visual assessment tool also, and it is being known as a funnel plot. So because of its shape, we call it a funnel plot. And as you can see, the dots are there inside the funnel. Those dots depicts your study. So if there is a study which is not covered by this funnel, it means that that study is an outlier and that is introducing heterogeneity in your study. Now, apart from this visual method, we have statistical method also to assess the publication bias, and those are Eagers and Beggs Majumdar rank correlation take. That gives you a significance value. So if your study comes out to have a significant p-value for publication bias, you again need to see the source of the study which is introducing the publication bias, and you might want to remove those studies. So there are certain ways like inclusion of a larger studies, trim and field methods. So I'm not going into much of the details of the studies, but these are the ways by how you can reduce the publication bias in your study. Now, till this point, we have just seen the advantages of meta-analysis, but there are certain disadvantages also. Like after a lot of things, you might get nothing in return. Your study might show that there is no conclusion, or you need little bit more evidence to come up with some conclusive findings. So great efforts are needed to undertake any meta-analysis. There is no consideration for the qualitative bias. As I have mentioned, it is only related to the numbers and the quantitative finding. There are certain piece of wisdom or really good information that lies in the qualitative data only, but meta-analysis does not consider it. So that is a one disadvantage. At times when the data is not available, or the authors chose not to report certain things, and that is a time when we end up comparing apple versus orange. So meta-analysis has always faced this criticism at time. It solely depends upon the findings of reported studies of a good for any good meta-analysis or systematic review. So at times what happens, gray literature also might have certain really good findings, or the studies which have never been published. They might be holding something really good information, but meta-analysis only take into consideration the published studies. So if your published studies are not of good quality, any good methodology that you follow for a meta-analysis, you will end up having a bad meta-analysis only, because the source of the information is not of good quality. So these are some of the disadvantages of meta-analysis. And I'll end up my session over here. And I'll open it for any questions or any points to be discussed. Thank you.
Thank you, Dr. Komal. Thank you, Dr. Komal. It was, thank you for your presentation. It was very enlightening. Now I request Dr. Soben Saha from IIPH Gandhinagar to present the concept of cost and cost analysis in health technology assessment. He is Associate Professor in Indian Institute of Public Health, Gandhinagar. Welcome, sir.
Yeah. Thank you, Dr. Viva. Can you give me right to share my presentation, please?
Yes, sir. Yes. Sir, hope you're able to share your presentation.
Yes, I can. Yes, then I hope it is properly audible. Yeah.
Yes, sir. Audible and visible also. Thank you, sir.
Yeah. Thank you so much, and good morning, all who have been part of this workshop. So after a nice orientation on evidence synthesis, including systematic review and meta-analysis that you have heard, so that is always starting point for any health technology assessment or exercise. So you always start with a proper analysis of what is already known. Once you have established that, then the next part is that, what about those concepts which are not known? For that, you might have to undertake certain exercises for a proper economic analysis. And basically, I would start with that. And I believe after that, there will be other speakers who would carry forward this with concepts on how do you establish quality of life. So I would take the part on cost analysis and discussing with you how that plays a role in economic analysis. So the outline is that I would basically start with some basics of cost analysis. How do you do cost analysis? Then we will talk about how do we measure outcome, and then finally how you use both cost and outcome for an economic evaluation. So basics in cost analysis, some of the things that we need to know is that what is cost, why do we care about cost, some of the taxonomies of cost, how are those costs categorized, and then we need to identify, measure, value, and report cost in a way that makes it important for the decision making. When you will do cost analysis for any program or services or product or devices, you need to have certain inclusion and exclusion criteria. What should be included in the study? What type of cost should be included? What type of cost should be excluded? What are the principles for inclusion and exclusion? If there are costs which are indirectly associated, how do you apportion the cost? Some of the intervention pathways and expenditure categories. So these are some of the things that we will be discussing first in the cost analysis component. First, we need to know what is a cost and what should be taken into account. So whether we should take only those costs which are in monetary values, or we should incorporate costs which are also in non-monetary values. So in economics, the focus is on resource use, which reflects the mission of economics, that is maximize welfare with available resource, and how you can come up with some choice for decision making. When we say resources are factors of production such as labor, capital that would be invested, land resources. Each of the resources is associated with certain costs, irrespective of who pays for the resources. Say, for example, if you go to do a cost analysis of a PHC, primary health center, now the land is more likely donated for this purpose by the Jila Panchayat or the Gram Panchayat. So is there a cost associated with that? In monetary terms, no, but in economic terms, yes. Does cost only involve those paying monetary values in financial analysis? Yes, but in economic analysis, no. Even if there are non-monetary values, for example, even if there is a donated good, a voluntary services, in economic analysis, you should estimate that what is the cost of that voluntary contribution, because it is irrespective of who pays, that cost has been incurred. What must be sacrificed in order to achieve a goal? So somebody is sacrificing their time, even if, for example, somebody has given a perpetual free license, they have sacrificed their time. If somebody else is paying for it. So it really doesn't matter whether the cost has been accounted for in monetary value, but that has to be taken into consideration. Now, certain taxonomies of cost. Cost, as you can see, there are land costs, there are building costs, there are manpower cost, and there can be consumable costs. Now, each of these costs are at different levels. So when costs are at different levels, it is pertinent that you classify it according to the level. So some type of costs are considered as capital cost. They are usually concentrated at the beginning of the program, and they contribute to your fixed asset. By the very term that it is contributing to a fixed asset, capital cost usually lasts for more than one financial year. So they are associated with the establishment of productive capacity, physical infrastructure such as land, building, equipment, vehicle, training, etc. There are costs which are all called recurrent costs. For example, if a building of a hospital is a capital cost, but procurement of equipment is a capital cost, but then there are recurrent costs such as paying for the electricity bill, paying for the supplies, etc. These costs are associated with operation or maintenance of the program, payment of salaries, equipment, maintenance, spare parts, utility, etc. Then there are costs which are called fixed costs. What are examples of fixed costs? Fixed costs are, say, for example, salary of professors at AIIMS Jodhpur. They are fixed irrespective of how many patients or how many students are enrolled into the program. Professors get paid a fixed salaries, right? These costs, those which does not vary in the short run. Remember, vary in the short run depending on output level. Example, building costs, central administrative staff salaries. Those are example of fixed cost. Cost that can vary depending upon the output level. For example, reagents for a test. No, these are directly proportional to the volume. These are example of variable cost. Drug cost, example of variable cost. So based on type, when you look into cost items, you need to think whether they are part of fixed cost, whether they are part of variable cost, whether they are part of capital cost. You need to treat your capital cost. Say, for example, the construction of a hospital building took 200 crore rupees. Now, by definition, the hospital building would last for say 30 years. It might need day-to-day maintenance, annual maintenance, but you don't tear apart the building, say within say 30 years period. So then you have to divide those costs by the 30 years to come out with the annual cost. But again, there are further treatment of it, which is called time value of money. Say, for example, a building have been built 10 years back. So 100 crore rupees spent 10 years back is not equals to 100 crore rupees spent today. So for every cost, you need to come out with a time value of that investment. So you need to treat your capital cost accordingly. So by expenditure categories, we talked about the capital cost, labor cost. If they are fixed term labors, then they are like health professional support staff. Then they are type of fixed cost. Consumable cost, by definition, most of these are variable costs. They depend upon the output level, medical, non-medical supplies, drugs, equipment maintenance. They are valued at market prices, etc. Then there would be some type of costs which are called overhead costs. These are common costs such as electricity, gas, accountant, cleaning, management services, etc. So these are called overhead costs, and there are different so overhead cost or indirect cost, they are to be apportioned based on the label used. So some costs are called direct costs. So they are directly meant for certain cost center. Say, for example, there is an X-ray unit. Then the cost of that radiologist who would be managing that X-ray unit would be a direct cost. But cost of the cleaning staff are example of indirect cost, also overhead cost, and you need to apportion those costs based on the time spent in that particular unit. In terms of microeconomic typology, cost can be also classified as total cost, average cost, and marginal cost. Total costs are basically the sum of fixed and variable cost. Average cost is the total cost divided by the number of units. Marginal cost is the cost of producing one additional unit of output. Say, for example, AIIMS Jodhpur as part of their MPH program, say, assume that they are producing 30 students. Now, Government of India would like AIIMS Jodhpur to increase their capacity of MPH students. So then what is the cost of producing one additional? Mind it, what is the cost of producing, not how much you are charging. What is the cost of producing one additional student in your MPH program is the marginal cost or the incremental cost of adding one additional volume. Now, coming to the stages of economic appraisal, we need to talk about, there are essentially 6 stages which Drummond has basically laid down, and everybody needs to follow that. The quite intuitive. Specify the research question. What is the question that you would like to address? First, when you are trying to do an economic analysis, you need to say what is the cost center for what you are doing the costing analysis. Then what is the question you are trying to answer? Say, for example, whether an intervention using IDAT technology, digital adherence technology, improves treatment adherence, TB treatment adherence, or treatment outcome among DSTB cases or DRTB cases. So that you need to specify the questions, and based on that, you decide what cost should be taken into account, what perspective you should take, whose perspective, and I will talk about perspective in a moment. What would be my comparison arm? You need to ideally have a comparison group. So what should be your comparison groups? What is the context of the study? What is the design frame? What is the timeline of the study? Specify detailed statement of alternatives to be addressed. What is the intervention pathway? What are the patient flow charts? Those need to be quite explicitly laid down. Assess cost and benefits of alternatives. So you need to, so for a good economic evaluation, for a full economic evaluation, you need to have an intervention group and a comparison group. So you need to assess the cost and benefit of both the intervention arm and the comparison arm. measure resources used and time saved by the program alternative. So remember, for any program, resources are consumed, that is true, but sometimes there can be time saved as well, and that needs to be valued into account. And I will show it with an figure illustrative diagram in a moment. Measure outcome produced for each, value resources used as well as resources saved, value outcome in appropriate unit, adjust for timing and discount cost and outcomes. If you're doing a costing of a multi-year program, then you need to adjust for timing. I talked about adjusting time, say for example, time value of money. So 100 rupees spent 2 years back is not equals to 100 rupees spent today. So you need to adjust for the timing, adjust for uncertainty. So for any estimate you come around, there can be uncertainty associated. There might be uncertainty associated with the COVID associated lockdown and the entire health system geared towards COVID pandemic situation. That can be an uncertainty. There can be cost of the specific drugs, say for example, RT-PCR test or the COVID, there's no COVID specific medicine, but the cost of diagnosis might come down if you are going for large scale program, or government caps the cost, or the cost of vaccines can come down if you go into scale. So there are a lot of uncertainties associated with that, even the supplies uncertainties associated. So when you are preparing a model, you come out with an estimate and you need to also have those uncertainty analysis in play. And then finally, you present your results to decision makers. So in the costing process, first, you need to identify what cost to be included and what cost to be excluded. You need to set that first so that whenever people are reviewing your protocol or your results, they are quite clear about what are your inclusion criteria, what are your exclusion criteria. Measurement, measure in natural physical units, say for example, hours or labor time, how much to be attributed to the intervention, how much of this cost to be attributed. Say for example, you are doing an intervention which is trying to work with a mobile health application for frontline health workers. Now, for that mobile health application, there is some cost associated with the mobile phone, with application development, but the frontline health workers also devoting some time every day to work with that application. Consequently, if they are working with the mobile application, they might have to do away with their paper-based forms that they were submitting earlier. So you need to value for those things, select a unit price to place monetary value on cost, opportunity cost, etc., adjust for inflation. You need to decide from whose perspective you are doing this study. Are you doing it from a societal perspective, from a government perspective, from a healthcare perspective, from a patient perspective, from an employer perspective, or a third payer perspective? There are differences from each of these perspectives. For example, if you're doing this cost from a government perspective, you need to only take account for, or a program perspective, you need to account for only costs that are borne by the program. If you're doing it from a patient perspective, you need to only account for costs which are borne as an out-of-pocket expenditure. While if you are doing it from a societal perspective, you incorporate both costs that are borne by the program as well as costs that are taken by the out-of-pocket expenditure of the patient. So the ideal recommendation in the DHR, Department of Health Research reference case, is that you should follow a societal perspective. Again, there are costs which are borne by the health sector as well as costs which are borne by other sectors. For example, if it is a diarrhea management cost, then there might be costs which are borne by directly by the health department, and then there might be costs which are borne by, say, drinking water sanitation department. So you need to adjust for costs which are both taken care by the health sector as well as costs borne by the non-health sector. For example, as you can see now with the resurgence of COVID-19 cases, there are certain costs which are taken care by the by the health sector, but there are a lot of costs which are borne even by the police department in terms of extensive policing, extra hours spent in terms of night curfews and deployment, and several other sectors which are giving relief to the people who are affected by the COVID-19. So they're not necessarily costs which are borne by the health department. So you need to adjust for it when you are doing a proper costing analysis. Now, in terms of who bears the cost, there are 4 types of cost categories: costs that are borne by the health sector, costs that are borne by other than health sector, costs that are borne by patient and family, and there can be productivity cost. There might be overall economic downturn which is happening, as we are seeing. If people are not able to go to work, there are productivity loss that is happening not only to the person who is infected, but the overall factories. So that cost need to be taken into account. Conversely, for any new initiative, there can be also cost saving. And the cost saving can also be by the health sector, other sector, patient family, productivity cost. So each of this need to be taken into account. So this is what I was referring to in terms of thematically how you can look into it. For any resources, any new program that is being introduced, there can be certain costs which are borne by the health sector, other sector, patient, productivity cost. And as a result, you can also see some effect, but also certain savings in terms of resources saved, time saved by the health sector, by the other sector, by the patient family, and overall productivity gain. So remember, when you're trying to do a cost benefit or cost effectiveness analysis, you need to look into cost and benefit or effect both for the intervention group and also as a control group. For every cost that is incurred, you need to also assess whether there are any costs saved as a result of their intervention. So that would make it a comprehensive, gives a comprehensive picture. So now with these things, let me move a bit into measuring outcomes. So once we know about the costing process, a couple of things I have said, I'll just repeat myself. First, specify your research question. Think about what is your intervention group, what is your comparison group. For each group, think about what all costs are incurred, irrespective of who is paying for it. If there is some cost which is directly borne by, because reference case of the Department of Health Research recommends societal perspective, which means you need to incorporate both costs that are borne by the program and costs that are borne by the patient provider. So costs are again of different types. If there is a multi-year program, you need to adjust for the time spent, time value of money. Okay, you have to convert all costs into one base year cost and then only come up with an annualized cost. Cost can be also of different types. If there are capital costs, you need to come up with an annualized value depending upon the useful life year of the equipment. If there is a direct cost, you can directly attribute it to the program. If there are indirect costs, then you have to allocate those costs based on their activity volume to that particular program. Say, for example, if an A&M medical officer of the PSCs are spending some time for a particular program, then you need to account for that time. Say, for example, if they are spending, say, 1 hour every day towards monitoring and TB adherence, digital adherence technology, then that time should be allocated, irrespective of whether it is charged to the TB program or it is paid by the overall state exchequer. So everything included. Then if there are some costs which are directly paid in monetary value, and there can be some costs which are in voluntary value terms. Say, for example, someone is volunteering their time, someone is given some programs perpetually free. All those costs need to be accounted for in your analysis. Then in terms of measuring health outcomes, I will touch upon some concept of measurement. I know that in the next session, you will be having more detailed discussion on quality adjusted life year. So I'll not touch that in details. But come out into the outcome measurements. Whenever for any program, and once you have understood about the cost, you need to also have the outcome to come out with an ICER value, incremental cost effectiveness ratios. So for outcome can be defined as a change in health status or results from provision or withholding of the healthcare. Say, for example, some of the hierarchy of question: does healthcare have an effect on patient health status? Can be distinguished the positive and the negative effect? Can those effects be quantified? Can those be aggregated into net measure of outcomes? So these are some of the questions that we need to address when we are thinking about the outcome of the program. Final outcome can be change in health status resulting from the program. Say, for example, whether the person is alive or the person has died. However, there can be intermediate outcomes. Why do you need an intermediate outcome? That depends upon the study duration. Say, for example, there is a program which intends to build make a difference in neonatal mortality, but you are trying to assess the program in a period of, say, 6 months period. So there, neonatal mortality within a 6-month period may be too short a time for pathway for change. Then you need to look into, say, for example, intermediate measure, for example, change in clinical indicators. Say, for example, how many births happened in an institution, what were the incidences of low birth weight babies in the institution. So this can be intermediate indicators. So depending upon the time duration, depending upon the pathway for change, you can come out with a final indicator or an intermediate indicator, something which will have a cause and effect relationship with your program. The central issue is that how do we measure health and how do we value health? Now, there can be some implicit and explicit value of health. Sometimes the value of health intervention can be easily identified. Sometimes this must be inferred based on indirect measurement in absence of primary indicator. For example, male suicide rates as a proxy for performance of mental health services. Or you can have classical indicators such as survival rates, readmission rates, symptom counts, employment status, days lost through sickness, or other clinical parameters. In terms of measurement of benefits of the program, that can be calculated as in terms of cases detected, number of people tested, lives saved, infection averted, life years saved or life years gained, daily saved or quality gained. I will speak a bit about disability adjusted life year, and I believe the next speaker will discuss with you in detail about the quality adjusted life year. Now, hospitals, there are classical indicators such as dead or alive. Crude mortality rate average around 3% of all patient admissions. The problem with this indicator is that we can be certain about the outcome for around 3 in every 100 patient admission. What we do not know is that what is happening with the remaining 97% patients who would be alive, whether they are relieved or unrelieved of their suffering. So, for example, if you look into typical survival rate indicators as an indicator, given 2 interventions in the treatment of head and neck cancer, treatment A has 60% survival rate at 5 years, while treatment B has 40% survival rate at 5 years. Which one of this would you consider as better treatment? If you thinking of an answer as treatment A, think about it. So, if you only look with a mortality-based indicator, then individual who lives for 5 years and 1 month is a success, while an individual who lives for 4 years and 11 months is a failure to you. So 5 years, 1 month of a poor quality of life is better than 4 years, 11 months with a good quality of life. Is that what you want to interpret? Right? So, which means that the typical survival rate with the indicator with the mortality indicator would not always be sufficient unless you take care of the morbidity pattern of it. So that is where we bring in the concepts of cumulative index such as DALY or QALY. I'll touch a bit about here with the concept of disability adjusted life year. It talks about the health gap measures that combine time lost due to premature mortality and non-fatal condition. Quantifies the burden of disease and injury of human population. Disability adjusted life year is essentially the amalgamation of 2 indicators, years of life lost and years of life lived with disability. YLL can be found out from standard life table with life expectancy at birth, with discounting and age weighting, with discounting on no age weighting, and without discounting and no age weighting. The issue is with the YLD, which is about the morbidity pattern, which is multiplying the average duration of the condition to remission or death. So you multiply it by severity weight. So YLD is a factor of incidence of the condition into disability weight into life lived with that disability. The YLD is the most difficult part because how do you come out with the disability weight? There is no single data sources. Need to understand the epidemiology of each disease and sequel of this. And that is where in that context, the global burden of disease comes up with disability weights for different disease conditions. So that's how you can use that to come out with disability weight for different conditions. So I'll take a pause here for the disability adjusted life year, and we'll because the next part of it, the quality adjusted life year, will be talked in the next session. So I will touch a bit about how you use this cost and outcome to come out with some decision around economic evaluation, which are essentially a set of tools to identify from among the different interventions to show to improve health, those which do so to greatest extent for a given investment in healthcare. So what you try to find out is that for every dollar that you are investing, for every rupees that you are investing, how much outcome are you getting and whether it is cost effective or not. So it's basically about you need to study both the cost and benefit, comparative analysis of alternate courses of action in terms of both their cost and consequences in order to assist in policy decisions. So you have some choice. You have got two programs, program A and program B. You estimate the cost of program A and cost of program B and the outcome associated with program A and outcome associated with the program B. So then what you do is that you compare, I calculate ICER or incremental cost effectiveness ratio is equals to cost A minus cost B divided by consequence A minus consequence B. And then you come up with a decision question. The final objective of the economic analysis is to maximize the benefit obtained with a limited resource. It measures the cost and consequence of activity. We need cost and consequences to do an economic evaluation. You can do it against the current practices. The reference case talk about do it against current practices. So there is a current practices, for example, is a mother and child tracking system for e-Mamta, and you come out with a new intervention such as a Teco Plus program in Gujarat, and you try to assess that whether this Teco Plus intervention has resulted in better efficiency, better survival, better morbidity management among mother and children. So that's what you would like to do, is compare against the current practices. Economic evaluations are of different types. You can have partial economic evaluation or a full economic evaluation. So this schematic table summarizes, if you have both cost and consequences measured for alternate things, then you go for full economic evaluation. If you only have either of these fulfilled, say for example, if you have the cost measured but not the outcome, which is in the y-axis, you can see it is a cost outcome description. If you have the no cost measured but not the outcome, then you go for an outcome description. And if you have only cost measured but not the outcome of the alternative, then you have a cost description or a cost analysis. So economic evaluation can be a full economic evaluation or a partial economic evaluation, depending upon what inputs you capture, whether you're capturing inputs on cost of both intervention and comparison group and consequences of both intervention and consequences comparison group, you come out with your analysis. So if no comparison, then the program or service is being described as outcome description or a cost description. If no comparison group is there, you have cost or outcome, then you go for cost of illness, burden of illness, etc. in this category. If both outcome and cost are described, then it is a cost outcome description. Say for example, you can come out with a per unit cost of this particular program. If only consequences across alternatives are compared, these are efficacy or effectiveness evaluation. So where you go for clinical trials, if only cost across alternatives are looked at, we have cost analysis. So whenever we remember, friends, when we talk, say this program is cost effective, you need to ask, how do you come out with a measurement, whether it is cost effective or not cost effective? Are you doing a full economic evaluation or are you going for a partial economic evaluation? So there are four types of economic evaluation. One is the cost minimization approach, which is the outcomes are considered the same in both the alternatives. The aim is to find least cost alternative. So that is called a minimalistic approach, minimization approach. However, the sameness is not common in real world. So it has a very limited role. So you are only compare which program, given or both the programs equal, which program is less costly. This is a cost minimization approach. You can go for cost effectiveness approach, where we compare different magnitudes of common measurement. So benefits are generally in medical or health terms like additional life years gained or saved, deaths avoided, result expressed as cost per health effect. So that is called a cost effectiveness analysis. Effectiveness analysis where you compare the cost of intervention and comparison of with some health effects, say cost per neonatal deaths averted, cost per infant deaths averted, cost per maternal deaths averted. These are example of cost effectiveness analysis. Then you can have cost utility analysis where you pose an utility value to the death or condition managed. Say for example, consequence or effects are expressed in terms of quality of life adjustment. Reduced morbidity and reduced mortality can both be integrated in one measure. I showed you an example with Delhi where you compare both mortality and morbidity. In the next class, you will show about QALY, how QALY can be calculated, quality adjusted life year. So when you are measuring it in terms of utility matrix, then that is called cost utility analysis. This is the most commonly used. Why? Because say for example, you have done a program which looked with neonatal mortality. I am doing a program which looked at infant mortality. Now I cannot compare these two programs. Which program I should be taking up? Because one is looking into neonatal, one is looking into infant. But the moment I convert it into utility matrix, then those two becomes comparable, right? So that is why this QALY or DALY is the QALY is now the most commonly used matrix of cost effectiveness analysis. Cost benefit analysis, when we need when benefits are in different units, we need a common measure, translate health effects into rupees value. That is the concept of cost benefit analysis. When we look into cost of intervention as well as the value of its health benefit. So you use a human capital approach or willingness to pay approach. However, cost benefit analysis is highly contentious because when you try to find put a monetary value to a disease condition, then there are concept of equity. So are you putting the health of Mukesh Ambani and a vegetable vendor at the same level? If you are not, then why not? Both of them are human beings. So this is highly contested. So they are less commonly used. The most commonly used in terms of economic evaluation is the cost utility matrix or cost utility analysis. So that's a basic concept about the cost, benefits, and some types of economic evaluation and how you can use this for your day-to-day when you are trying to do an operation. Now, remember, some of the closing remarks, friends, these are some of the references that you can look in. Department of Health Research and both IIPG and AIIMS Jodhpur are regional resource center, and I believe Dr. Pankaj and Dr. Kuldeep has already spoken about it at their introduction. So DHR has come out with a reference case. This is currently a draft reference cases, and then there are several cost information that you can find out. PGI Chandigarh, I think the next speaker will be from PGI Chandigarh. So there are cost databases that PGI has created. So a lot of this information, cost information, you can get from online sources. Even when we do our studies, we refer to those cost bases. There are some in data that you need to calculate from primary sources, but then there are other data, cost data that you can get from publicly available data sources. So you use both this information and you then decide which information you need to collect from secondary sources, and there are things which can be done from primary sources. The reference case is something I believe it will be discussed during this today's session. It's something that one must refer to for coming out with the that how should you carry out your cost effectiveness analysis, which cost you need to take into consideration, which effect you need to take into consideration, and then come out with a composite matrix. Okay, so maybe I will stop here, and if there are any questions, I can address those questions in the next couple of minutes that we have. Viva?
Thank you, sir. Thank you so much, sir. I think it was a very descriptive presentation in a very short period of time. Sir, can you hear me?
Yeah, I can hear you. Thanks. Thanks for that.
Thank you so much, sir. And I would request participants, if they have any questions from the speakers, please put your questions in chat box. Sir, we didn't get any questions. So if we get in few minutes, we'll let the question answer round be later after this presentation.
Yeah, that is absolutely fine. Thank you.
Thank you, sir. Thank you so much, sir. The next speaker for our today's session is Dr. Gaurav Jani. He is a research officer and PhD scholar in Department of Community Medicine and School of Public Health, PGI, Chandigarh. His contribution is development of health-related quality of life values set for India. He's working on that. Assessment of health and economic burden of alcohol use in India, economic evaluations of various preventive and therapeutic interventions in India, and assessment of patient-reported outcomes. He is working with Dr. Shankar Prinja in PGI Chandigarh. Now I welcome Dr. Gaurav. Dr. Gaurav.
Hello, thank you, Dr. Vibha, for the introduction. May I get the screen sharing rights?
Yes. Yes.
Yes, got it. I'm sharing my screen.
Okay.
So, is it visible to you now?
Yeah, it is visible. Yeah. Now it's in.
Okay. So, as we know that the aim of almost all the public health interventions is to maximize health of the population. And in our discussion since morning, we have learned that HTA is a very promising and globally accepted tool to achieve universal health coverage. And in our last lecture, Somin sir has beautifully explained that in order to do HTA, we need to perform economic evaluation, also known as cost effectiveness analysis in the common parlance. And what is the purpose of doing economic evaluations? The purpose is to know that if there are more than one options available to address a health problem, which option will offer better value for money. And to do this, we need to compare two things. First, what is the cost of implementing the different options? And second, what are the health benefits? So in the previous lecture, we have learned about measurement of costs. And in this discussion, we will try to understand how effects are measured or how consequences are measured in economic evaluations. So this we have already discussed in the previous lecture. Here we will try to understand the concept of measurement of health. The cost we have already understood. So in measurement of health and health gains, we will try to understand what is the role of health related quality of life in measuring health gains. That why it is important in our analysis, how to correctly measure it, how to use this data in economic evaluations, and finally, what are QALYs and DALYs, so that if we come across an article talking about QALYs or DALYs, we can interpret what authors are talking about and how they would have calculated it. So based on the measurement of consequences, there are broadly three types of economic evaluations: cost effectiveness analysis, cost utility analysis, and cost benefit analysis. There is one more type of economic evaluation, cost minimization analysis, that is also considered a part of cost effectiveness analysis. So in our previous lecture, Somin sir has beautifully explained that what are the different types of economic evaluations and which analysis we should use. So in Government of India guidelines to conduct HTAs, cost utility analysis is recommended. And why it is recommended, as sir has explained, that suppose I am doing a study on cervical cancer and you are doing a study on malaria prevention, then if outcomes will be different, so at the end of the day, we will not be able to decide on the simply on the basis of the clinical endpoints, on the basis of different outcomes, that which intervention is cost effective. So there should be a uniform comparator. So in cost utility analysis, consequences are measured in utility based quality of life scales or QALYs or DALYs. So on the basis of that, we can compare all the intervention, no matter the intervention is measuring effect of malaria or cervical cancer or thalassemia, no matter whether it is a preventive intervention, whether it is a curative intervention. So now we will first discuss the concept of QALY and DALY. So when we talk about measuring the health of the patient or capturing the effect of disease on a person, we define it as a function of two components, which are mortality and morbidity. Mortality tries to explain the length of life, whereas morbidity tries to explain the reduced quality of life. So the concept of QALYs and DALYs is an attempt to describe both these things within a single number. They are kind of flip sides of a coin, but they are not interchangeable because the way they are calculated and the way they should be interpreted, that is different. So what is QALY? QALY is actually number of years lived in perfect health. On the other hand, DALY is number of years lost due to ill health. So in other words, we can say that when we talk in terms of QALYs, I would say that if I use this intervention, this much amount of health gain I will accrue. Whereas if we are talking in terms of DALYs, we will say that if I will not use this intervention, I will lose these many disability adjusted life years. So we can also understand this with another example, that QALY describes how long a person lives and how well he lives during those years. Whereas DALYs try to tell us that how early a person dies because of a disease. And when the person was alive, what was the level of disability the person was facing. So this is the basic difference between QALYs and DALYs. So in both the concepts, the overall idea is that 1 unit is equal to 1 year of perfect health. In terms of QALYs, it is the years of perfect health gained, whereas in DALYs, it is years of perfect health lost. But as I have said earlier also, they are not interchangeable. That why they are not interchangeable, that we will learn in subsequent slides. So first we will discuss about QALYs, because QALY is recommended in Indian reference case to be used as an outcome measure in health technology assessments in India. So QALY, as we have learned, that it is a measure which combines two things, length of life and quality of life. The idea of length of life we get from survival studies, and the idea of quality of life we get from utility score. What is utility score? Utility score is actually an index which represents the health related quality of life of an individual. We will discuss about this in detail in subsequent slides. So utility score ranges from 0 to 1, where 0 denotes death and 1 denotes perfect health. So suppose my health today is around 80% as compared to a perfectly healthy individual, then my utility score today will be 0.8. So, I mean, as you have understood that it is quite a subjective thing, and it is difficult to give my health a rating that I'm 80% healthy as compared to a perfectly healthy individual. So there are some way outs how to capture it correctly that we will discuss now. First, we will try to understand that in economic evaluations, how we measure QALYs actually. Suppose a person is living for 70 years. So he will live for 70 life years. And let us assume that throughout his life, he did not face any health problem. He lived all his years in perfect health. So his utility score was 1. So Quelly's lived is equal to survival, that is 70 years, multiplied by utility score, that is 1. Now, let us assume that the quality of life of that individual throughout his life was 60%, which means as compared to a perfectly healthy individual, he was 60% healthy. So his utility score was 0.6. So the Quellies lived, how do we calculate? He lived for 70 years, that is survival, and we multiply that with utility score of that person during those years. So it is 42. So actually the person lived for 70 years, but the years he lived, which are equivalent to perfectly healthy years, is 42. So this is the concept of Quelly. So we try to understand this with the help of very crude example, because quality of life cannot remain same throughout the life. It will change. So how do we capture it, and how we address to the subjectivity which this subject has, that we will learn in subsequent slides. So as I have said that the quality of life changes with time. So let us first try to understand that how do we incorporate this effect in our studies. So here you are seeing a graph. On x-axis, survival is plotted in years, and on y-axis, utility score is plotted from 0 to 1. 0 means death and 1 means perfect health here. And suppose we are studying two treatments of a disease, treatment A and treatment B. Treatment A is represented by red color and treatment B is represented in green color. So the patient on treatment A will live for 5 years and then he will die. So number of life years lived by this patient will be 5. And during those 5 years, what will be the quality of life of this patient? It will be 0.5, which means he will be 50% healthy as compared to a perfectly healthy individual. So throughout his life, throughout the survival which is there for 5 years, which the drug is offering, his quality of life will remain same. So what will be the number of perfectly healthy years, or what will be the number of quality adjusted life years this patient will be living? 5 years multiplied by 0.5, that is 2.5 years. Now let us talk about second patient. The second patient is receiving drug B, so he will survive for 6 years, and for first 3 years his quality of life will be 0.6. So 3 multiplied by 0.6 is equal to 1.8 quellies in first 3 years. After 3 years, his quality of life will increase. It will increase to 0.7 and he will live for 3 more years. So he will live for 3 multiplied by 0.7, that is 2.1 quellies. So overall, he will live 3.9 quellies. From the starting of treatment till his death, although he will remain alive for 6 years, but these 6 years, when the effect of quality of life is factored in, is equivalent to 3.9 years of perfect health, or 3.9 years of 3.9 quellies. So as we see that patient on drug A lived for 2.5 quellies, whereas patient on drug B lived for 3.9 quellies. So the gain in quellies is 3.9 minus 2.5, that is equal to 1.4 quellies, which means that if we go with treatment B as compared to treatment A, there will be a gain of 1.4 quality adjusted life years. So this was also a kind of oversimplistic representation of how quality of life is incorporated and how qualities are measured in economic evaluations. Actually, with every passing year or with every passing cycle, quality of life keeps on changing. It depends on a lot of factors. It depends on the stage in which a patient is, the disease stage. As it progresses, the quality of life usually decreases, and there are many more factors. But the basic idea behind this is we calculate it in this fashion. So the idea about survival we get from control trials or survival studies, but how to calculate this utility scores, that we will discuss now. So this part I will not be discussing in detail because sir has already explained. Let us quickly look at the calculation of Delhi's also, so that we can make a difference that how query calculations are different from Delhi calculations. So as sir has explained in the last lecture that Delhi is actually a combination of two things. It is addition of years of life lost and years lived with disability. So suppose in a country life expectancy is 75 years and a person dies at the age of 50 years because of a disease. So how many years of life that person has lost? That is 75 minus 50 is equal to 25 years. So this was the first component of the daily, that is years of life lost. And now we see how years lived with disability are calculated. So as we have seen, that person dies at the age of 50 years, but suppose the person turns blind at the age of 45 years. So for 5 years, the patient will remain blind also. And the disability weight for blindness is 0.6. So the years lived with disability is 3. So total days that the patient lost is years of life lost, that is 25 years, plus years lived with disability, that is 3 years. So 28 days will be lost because of this disease. First reason was the person died early, and the second, for 5 years he did face some health problems. Because of those health problems, his health was not appropriate, so some disability weight was assigned. Now it is worthwhile to mention here that this disability weight is actually inverse of utility weight. Its calculation is different, its method of interpretation is different, how it is derived, that is different. And in utility weight, in utility score, 0 denotes death or no health, and 1 denotes perfect health. Whereas it is inverse, it is disability weight, which means 0 means no disability and 1 means uh, death. That means the disability of extreme level. So the range of both utility score and disability weight is 0 to 1, but they are inverse. In utility score, 0 means death and 1 means perfect health, whereas in disability weight, 0 means 0 disability, that is perfect health, and 1 means death. So as sir has explained, global burden of disease estimates are available, and we can have those disability weights from there, but they are kind of not recommended in India in economic evaluation, so we will not discuss those in details. Now we will quickly try to understand that how these qualities are actually measured from population, because it is a very subjective matter. As I have said, that suppose I'm 80% healthy as compared to a perfectly healthy individual today. So how I can arrive at that conclusion? So to capture this subjective aspect in an objective manner, scientists have devised some instruments, and the most common instrument which is used in economic evaluation across the globe, which is recommended by almost all the central HT agencies of countries, is Eurocall 5-dimension questionnaire, EQ5D. So it has two parts. One is visual analog scale known as EQ-VAS, and second is a descriptive system, that is EQ5D5L. EQ means Eurocall, 5D means 5 dimensions, and 5L means 5 levels. So what are these two parts and how we capture the responses of respondents on this? So this VS is actually a thermometer-like scale. It is a 20 centimeter long line with the points plotted on it from 0 to 100, where 0 is the worst health that your respondent can imagine and 100 means best health. So suppose I ask you that how many marks will you assign to your health today out of 100? So based on your own calculations, maybe you will say 75 or 80. So we'll record that response. So it is kind of a direct valuation of patient's health. So this is how this questionnaire looks like. We simply record the value which patient suggests. And the second part of instrument is actually a more comprehensive part that is known as EQ5D5L descriptive system. In this descriptive system, there are 5 dimensions as the name suggests. And what are these dimensions? These dimensions are actually some attributes of the patient in which health change can be manifested so that we can record that. So these dimensions are: first is mobility, second is self-care activities like dressing and bathing, third is usual activities like doing household chores or going office or some leisure activities. Fourth dimension is pain and discomfort. And fifth dimension is anxiety and depression. So with all the dimensions, there are 5 levels attached, where level 1 signifies that patient is having no problem in this dimension, and level 5 signifies that the patient is having extreme problem. So there are 5 dimensions, and there are, with each dimension there are 5 levels. So we go to our patient and we simply ask one by one that, do you have any problem in mobility? If yes, what is the level of your problem? Then with second dimension, then with third dimension. That's how we record the responses. So this is how this questionnaire looks like. And suppose our patient will say that I have no problems in walking about. So it is level 1. In second dimension, he is having problem of level 2, then 3, 4, 5. So we will get a 5-digit number based on the levels, where the first digit signifies the level of problem in first dimension, second digit signifies the level of problem in second dimension, and so on. So at the end of this exercise, we will get a 5-digit number, which we call as health state. So this will actually be the health status of the patient. But our overall aim is to know about utility score, not about health state. So we need to convert the health state that has been told to us by the patient to a corresponding utility score or quality of life score. Now, how do we do that? We need a value set for that. What is a value set? So as we have seen that there are 5 dimensions of EQ5D5L, and every dimension is having 5 levels also. So if we consider all permutations and combinations, so 5 raised to power 5 is equal to 3125 types of health states are possible. One health state is this: 1, 2, 3, 4, 5. There can be 2, 1, 3, 3, 4. There can be 3125 possible health states and their corresponding utility score. So value set is actually a kind of table containing a utility score for all the corresponding health states. So that while doing our economic evaluation, if we record simply the EQ5D5L response of our patient, we can convert it in the corresponding utility score. And this depends, the generation of this utility score depends, I mean, a lot of factors play their role, like what is their contextual perception about their own health, what are the kind of health services available in the country, what is the socio-economic status of the patient. I mean, a number of factors can play the role how a person perceives his own health. So after accounting for all these factors, we have generated a utility score. So previously we were not having this value set. We were not having our Indian utility scores. So we used to resort to foreign studies for these. but recently we came out with this Indian EQ5D5L value set. IAPH Gandhinagar was one of our collaborators in this study. So around responses of around 3,500 population was considered across the India. And after those responses, after some statistical modeling, we arrived upon the utility score of all 3,125 individuals. So how do we value the health states in order to generate the utility score? Or if for a country utility score, value set is not available, then how can we generate instantaneous utility scores? So for that, we use primarily three techniques: visual analog scale, as we discussed earlier. There are two more techniques: time trade-off and standard gamble. But in the interest of time, I will not go in further details for these techniques because now Indian value set is available, so we need not to perform these exercises. This also, sir has explained a bit that in order to do cost benefit analysis, we need to assign a monetary value to every health gain. Because in cost benefit analysis, not only the cost is measured in terms of rupees, the outcomes are also measured in terms of rupees. So for that, this conversion of health gains into monetary terms is required. So for that, we use some approaches like human capital approach, friction cost approach, contingent valuation approach is there. So based on all these approaches, we can convert the corresponding health gain into monetary terms. So before we wind up the presentation, let us have a quick recap of what we have discussed. We know that in order to do HTA, economic evaluation is required. In economic evaluation, two things are required: costs and consequences for all the available alternatives. Then we weigh against each of the alternatives, alternative against one another in terms of their costs and consequences. The cost is already covered in the last lecture. We always measure cost in terms of rupees, whereas how we measure consequences, that will describe what type of economic evaluation we are doing. So in India, we resort to cost utility analysis because it ensures comparability across the interventions, across the diseases. And in cost utility analysis, we usually use QALY only because that is recommended in India and the most widely used summary measure of the disease burden. What is a QALY? QALY is actually an indicator which tells us that how long a person lives and how well he lives. So if somebody says that a person is living for 5 additional QALYs, which means that he will be living life equivalent to 5 years of perfect health. And how QALY is calculated? It is calculated when survival is multiplied with utility score. Survival we get from survival studies or RCTs, and utility score we get from EQ5D. There is an instrument which has two parts, EQBS and EQ5D5L. So that's how we get the response. As a result of this questionnaire, we get a health state. Then we convert this health state into its corresponding utility score with the help of a value set. So that's how we calculate QALYs in our economic evaluations. So if we need to convert that in monetary terms, then we further convert those values using any of these approaches. So due to time restrictions, I could not go into details of some of the aspects, but if you are interested, then some free online courses are available on health economics website of PGI School of Public Health. You are welcome to visit these and register for free courses. So that's all from my side. If there are any questions, so I will be happy to answer.
Thank you, Dr. Gaurav Jani. Thank you, Dr. Gaurav.
Thank you, Dr. Weber.
It was a very descriptive presentation, and I think the participants would have gain an insight of Delhi and Delhi in a very descriptive manner. Thank you. Can we take a break for 5 minutes because Shankar sir will be joining in next 5 minutes. Good afternoon, Dr. Shankar sir.
Hi, good afternoon.
Now we have Dr. Shankar Prinja, Additional Professor of Health Economics at PGI Chandigarh, Department of Community Medicine and School of Public Health. He is member of many committees and he has contributed to more than 200 research papers and book chapters in leading national and international peer-reviewed scientific journals. He is also academic editor of PLOS One, member of the editorial board. And he's right now as he's the PI of Regional Resource Center, PGI Chandigarh of Health Technology Assessment. I welcome you, sir, to the workshop. And
Should I start, Vibha? Vibha, do I need to start?
sir, am I audible?
Yes, now I can hear you.
Sir, please, we're waiting for your presentation.
Okay, so sorry, I don't have a presentation. I'll be speaking without a presentation. Is that okay?
Yeah, that's fine, sir.
Okay, fine. Thank you so much. It was about 20 minutes, 25 minutes talk, so I didn't want to have a presentation. I thought I'll just speak and talk about the issues that you have asked me to speak on. So thank you very much for the opportunity to deliver this lecture. And I've been asked to talk about the implementation challenges and opportunities for HTA in India. So I'm sure that the previous speakers who have spoken before me must have given a good overview of the HTA system that has been created in India. And this HTA system is centered around a secretariat that is located within the Department of Health Research. And there's a hub and spoke model that has been created with several regional resource centers and technical partners out of academic institutes and research bodies who are commissioned the topics to conduct an HTA study. Broadly speaking, if I would try to summarize that, what are the applications of HTA? Then I would say that especially in Indian context, there are 4 main applications that I can summarize for health technology assessment. The first application for HTA is around informing the program design. And the reason why I keep it as one of the as I'm listing this intervention is because given the journey journey of universal health coverage that we are in currently, this happens to be one of the most important areas where topics are nominated and where several of the HTA studies have been conducted. So what it means is that essentially the topics that come to the HTA board for conduct of a assessment are not topics which ask a question of whether or not to do something or not. But the question largely is how to do a particular thing. So that's why I'm saying that the questions around health programs are mostly centered around trying to inform the design of the program. So for example, there have been several HTA studies that have focused on the screening programs. So whether it is screening for breast cancer, whether it is screening for cervical cancer, or screening for the hypertension and diabetes. But in each of these questions that are being evaluated, the question is not really exact that do we do the screening or do we not do the screening? The question is much more around how do we do the screening? So in terms of how do we do the screening, the question is that what should be, let's say, the cutoffs that you should be using for diagnosing somebody as screen positive, or which population age group should you be screening in order to for the program to be cost effective? What should be population age group that you should screen, and frequently should you be screening? So those are the nature of questions that we have seen that come as major important topics for which evaluations need to be conducted. So that's one big area of work around HTA, is to inform the program design in order to improve the efficiency of the programs, health programs. And the reason why this becomes very important is because there are several known cost-effective that are available in the literature and which are not scaled up to the level that it should be. So these interventions are not universally provided to everyone. So when they become part of the program, the cost effectiveness as such of a yes or no question is already determined. But what is not known is that how to do this in the best possible way in the Indian context. So that's what has been the focus of the evaluations that have been conducted in the last couple of years in India. The second stream of application of HTA in India has been around trying to inform the health benefit packages. So the question here is now that whether we include a certain drug, whether we include a certain device, or whether we include a certain intervention in the benefit or not. And the recipient of such evidence largely are the programs around insurance, such as the PMJY scheme, or the states that are implementing the PMJY, which are the state health authorities. So the question there much more is centered around, for example, whether or not to provide, let's say, heart transplant, or whether or not to provide the knee replacements, and if the knee replacements are to be included as a package, then which implants should be considered as cost effective? Or there are certain other questions also. For example, there is we had a question wherein they said that there are certain type of disposable syringes that are being used. What if we replace these disposable syringes with a new type of variant of syringes, which are called a safety engineered syringe? So this safety engineered syringe is something that cannot be reused, etc. So that was the question. So the second nature of question that tends to be evaluated is the question on health benefit package and what goes in and what goes out. So whether include new drugs. So there is let's say a new drug that is to be used for cancer, and there's a new molecule that has come up. So the question is, does the NHA, does the PMJY scheme pay of cancer patients molecule? So that's the question. So this is one of the areas that tends to be evaluated. The third question, the third application of HTA that we have seen so far in India is around pricing. So we know that there is a certain drug, or we know that there is a certain device that may not be cost effective as of now. But if you're able to lower the prices through better price negotiation with the manufacturer, then you're able to make that drug or device cost effective. So HTA helps to generate evidence that shows you that a given drug or a given device is cost effective below price. So this becomes very important when the agencies that are involved in procurement decisions are to make these price negotiations with the manufacturers. So, example of such an HTA study is a study that has been recently commissioned about a year back by the HTIN, which is trying to look at the cost effectiveness of about 40 plus anti-cancer drugs that have come under price regulation. And they're trying to evaluate that, we're trying to evaluate as part of this assessment that even if these anti-cancer drugs are not cost effective at the current prices, then how much should the prices of these drugs be regulated such that these drugs become cost effective? So this is a question that could be, the evidence could be used by both type of agencies. A, the ones that are procurement agencies who are involved in decisions around negotiating prices, or B, the regulatory agencies that would like to have a kind of a broad brush price regulation of that particular anti-cancer drug. So that's the third application. So the first application I said was around defining the program design. The second application is around health benefit package. The third application that I've suggested here now is around generating evidence for better price negotiations. And the fourth and the last application that I see for HTA in India is to inform standard treatment guidelines. So this is one area which is very much needed, but which is the most difficult perhaps. So we know that there are a lot of standard treatment guidelines that are available, some which may be developed by, let's say, the government, by the ministry, some which are developed by state departments of health. Other standard treatment guidelines are also available that might have been endorsed by the individual professional bodies, such as, let's say, the IAP for pediatrics, or maybe the FOGSI for the obstetrics and gynecological treatment guidelines. But in all these treatment guidelines that are prepared, the fundamental evidence that is used for developing treatment guidelines are clinical evidence. So which means that how effective is the given drug? So how many years of survival does a new drug add? Or how much is the reduction in the rates of recurrence of this given disease? That's an important question for oncology drugs. So those are the kind of that's the kind of evidence that is generally looked at. But what is grossly lacking right now in these standard treatment guidelines is the use of evidence that also evaluates a given drug on grounds of cost effectiveness to say worth the value for money or not. So those are the four broad applications that I see where there is a role for HTA to play in the current scenario in India. However, having said that, moving forward to the other part of the topic that has been given to me is around what are the problems, challenges in implementation of HTA. So the challenges in implementation of HTA, I'll try to classify the challenges into 2 or 3 categories. The first set of challenges that I'll try to highlight are the challenges that are with regards to production of evidence. And the second set of challenges that I'll try to highlight is around the transfer of evidence to policy or decision for that matter, even if it is not a policy that is to be made use of by the government. So those are the 2 broad sets of challenges that I'll try to highlight. Related to production of evidence. Challenges for production of evidence. This is related to both the factors related to demand and supply of HTA evidence. So, for example, we do not have right now enough capacity that could help generate the right volume of evidence that is required for decision making using HTA. So we have very limited capacity right now in India. So we are very much into what I can say as infancy of developing the systems for health technology assessment. Although if you look at the pace of the journey in India, I would say it is by far faster than several other countries that have tried to develop HTA systems for evidence-based policy. So so much that we are not able to meet that with given the current capacity that we have for generating evidence. So that's the first challenge that we have. And the other set of challenge in the production of evidence also comes with the set of background availability of data that is available for a much more faster and smoother conduct of HTA. So which means, for example, majority of the good established systems of HTA where countries have been able to make use of HTA evidence have actually built upon existing systems of data that are repositories that are created for A, the cost of healthcare services, or B, the data on evidence of healthcare interventions, and C, for example, on, let's say, the utility values for different healthcare states to measure the quality of life. But such existing repositories of data were largely at least absent in the early years when we started establishing HTA, and as a result, it took the last couple of years also went into trying to establish such background repositories and data systems that would help to conduct HTA assessment. So for example, there's been a move around creating national health system cost database. There is also been a study that has been conducted and which has led to development of a value set. I'm sure Gaurav would have spoken about that in the previous talk, and he would have given an illustration of how that value set has been developed and which is now available to HTA researchers. But in the past, such value set was not available. So which meant that the researchers had to either do much more primary to come up with these utility values, or maybe use the utility values that have been published have their own limitations. So that's one kind of challenge that goes towards generating the evidence, which is either linked to data systems or linked to the capacity. The second set of challenge is around the use of or the transfer of this HTA evidence to policy making. And that's where there is a lot of softer side of the science that comes into play. For example, one big challenge that centers around the uptake of HTA evidence for policy is the kind of political economy that we have in our country. So most of the countries, HTA has been successful for supporting evidence-based policy making are those settings where there has been single payer system. So what I mean by a single payer system is that there is a large government funded program that pays for the healthcare needs of the population. So for example, we know that HTA, let's say the success stories that we hear from UK. But when we look at UK, there is a agency called NHS, which is the National Health Service, which is the single largest payer or the financer of healthcare services. Or the second example that we keep hearing very often is around closer home is the Thailand, where again they have an agency called HITAP that supports policy making decisions, but then they have a large universal coverage scheme that pays for the healthcare of the large majority of the population in Thailand. And other than that, there are a couple of other schemes which are for the central government employees or certain other focal population groups. But the key point here is that there is a large scheme or a large program or a large government entity that pays for the healthcare needs of the population. And when this kind of a situation happens, then this is the single largest payer for purchasing healthcare service. And as a result, if there is a single largest purchaser, then whatever HTA evidence, whatever decision that an HTA evidence leads to gets implemented on a very large base scale, and by the regulatory conditions or by the conditions of provisioning that are created by this single largest payer, it is able to regulate and ensure the adherence HTA decisions that have been issued. So for example, let's say there is a new drug that is available for treatment of breast cancer. Let's say there is a drug called trastuzumab. Now, if NHS says that it is, which is the HTA agency in UK, if it says that it is not cost effective, then the NHS does not include it in the benefit package. And if the NHS does not include it in the benefit package, then you can assume that 90% of the people who are suffering from breast cancer and who are dependent on the NHS services would not be able to get it, obviously. So which means that decision that comes as a recommendation from the HTA agency gets to be applied and applied at a much more larger population-wide scale. But the problem that comes in India is that we have a multi-payer system, and the system of financing is such that each individual, by and large, pays for the healthcare that he or she seeks when he is ill. So close to about 70% of all our healthcare expenditures are private expenditures, 72%, and nearly 85% of this private health expenditure is something that is paid out of pocket. So in such a situation where more than 2/3 of the total healthcare expenditure is paid out of by households, each of the household becomes a payer in itself. And then what it means is that the decision for providing healthcare is largely contingent upon a discussion that takes place between the doctor and the patient. And what this leads to is that the sole driver of decision for providing a given healthcare service is the affordability of the patient or the paying capacity of the patient. So if the patient is willing to pay, if the patient is able to pay for this drug, trastuzumab, then he is given a prescription. If the patient is not able to pay, then you don't prescribe trastuzumab to that patient. Now, this is a relatively fortunate situation in terms of financing that we are in, but then this inevitably creates a very difficult context within which the decisions on HTA could be made enforceable to on the providers of the healthcare service or on the payers of the healthcare service as well, because everybody has a decision to make then in that case, and there is not one. So the single most important impediment to the use of HTA or the application of HTA, I would say, is the context of financing in which we are. And as a result, the way forward then that it leads us to is something that is linked to political will, and consequent to that, a legislation that should be brought about, and also a transformative shift in the pattern of financing that we are currently in. So I'll take the first one first, and that is around the legislative component and the political will that I mentioned about. So the first thing that needs to be done is to have a kind of a legislation that tries to bring about tries to give at least somewhat bigger statutory power to the HTA agency or the HTA body, such that the decisions of the user or the funder of healthcare is contingent upon the evidence that the HTA body gives. So what it means is that if the HTA body recommends a given drug or a device for use for use in the program, then the decisions of the Ministry of Health or the decisions of the clinicians ultimately should be bound to based on the advice that is being given. Right now, we only have recommendatory power to the HTA body. But if this is taken forward to make it more of a statutory power, then it gives much more teeth to the HTA agency and much more linkage of evidence to policy making. Now, there is some effort in this direction, and there is a HTA bill that has been tabled and that is being considered, that is being prepared. And it is being proposed that this bill is likely to be tabled in the Indian Parliament in the monsoon session. But to what extent does it really offer the kind of the statutory role is something that needs to be seen and would be obviously discussed. The second opportunity or the way forward that I see is a much greater interaction between the HTA agency and the somewhat single largest payer that we have currently, which is the AIIMS Bharat PMJY, which is run by the National Health Authority. And the reason why this becomes very important is because PMJY right now, at least for the purpose of provision of curative care, does control to a certain extent the behavior of the providers who are empaneled under the scheme. And so if the PMJY defines a certain benefit package, which includes certain drugs and does not include certain drugs, then obviously the decisions of defining those health benefit package, if they are linked to HTA evidence, that becomes another very good starting point for use of HTA evidence into policy making. So I think that these are two major important areas. So one is political will and legislation. Second is the increased linkage between the HTA body and the PMJY. And the third, which is another very important area, is around building capacity. And because you can't just only do with creation of demand for HTA evidence, but you also need a very large supply of HTA researchers who could generate such evidence that is required by policymakers. Because right now the problem is that we keep getting so many topics in the HTA secretariat, and not all of those topics can actually be conducted within a reasonable period of time. And policymakers are not, ready to wait for that long to generate for the evidence to be generated, because decisions in policy making are done in more of a real-time basis. So they are in an absolute hurry. So the HTA researchers also need to create that kind of a capacity in order to generate more evidence and generate more quality evidence within a shorter time frame, such that it becomes meaningful for policymakers as well. So maybe I'll stop here because I think I'm running out of time and I have just 5 more minutes there to go. So I'll be happy to take any questions on this.
So we have a how to convert health state to utility scores.
Okay. So the question for you is, the question that you're asking is that how to convert state to utility scores. Okay. So there are two options, and I'm sure that Gaurav would have probably covered this part. So right now, the job of converting a health state to a utility score has been made much more easier with the creation of a value set. So right now, what you need to do is that if let's say you're interviewing a certain set of patients with a certain disease category, and based on that interview using the EQ5D tool, you arrive at a health state, you simply need to refer to the value set and see that what is the utility value of this particular health state, and simply apply that utility value. If, for example, you did not have this value set and you wanted to a priori arrive at a utility value, then the only way forward is that you need to conduct another second set of research, which is using techniques of either time trade-off or standard gamble. And you need to apply these techniques in order to interview the patients again to say that how much time would they be willing to trade off for being in this health state versus to be in the perfect health. And depending on that, you would be able to derive a certain utility value. But I think that having a value set obviates the need to engage in this second exercise, which is very time consuming, requires a lot of skill set, because these interviews have to be very detailed and have to adhere to certain standards. So I think that with the value set being available, the job of HTA researchers is quite limited and quite the scope is reduced. So it helps the HTA researchers to finish up the work in a more reasonable period of time.
Thank you, sir.
So thank you, Dr. Shankar Prinja. This was very useful presentation by you regarding this health technology assessment challenges and opportunities in the public health. And as you rightly said that the government policies are dependent on the evidences, and there is a need for collecting those evidences through a high quality research, which can be done in a reasonable time. And basically, if more researchers can be utilized and more health technology assessment centers are there, with the capacity building have been conducted through these type of workshop, I think we can have the more research evidences in a shorter period of time. But again, Dr. Shankar, you have given a very good ideas about how we can move about. I think it was very helpful for all our participants who are participating in this event about the health technology assessment in the public health. So we are very grateful to you for. And we'll definitely look forward to your further guidance, because you have a lot of expertise in this area in the country and also in this region of Southeast Asia. I think definitely we are going to benefit from your expertise. And at any time, the people can give their thoughts or their questions, and we can involve you in more of such activities in the future. we'll definitely look forward to you and your for guidance. Thank you, Dr. Shankar, for a very
Sure, sir. Thank you so
comprehensive,
much.
very important presentations for the public health. Thank you.
Thank you, sir.
Thank you, sir.
Now, I will also like to thank all the speakers who have given their thoughts during this presentation. Dr. Pankaj Bharadwaj, Dr. Deepak Saxena, Dr. Suman Saha, Dr. Gaurav Jani, who have given a lot of information about the different aspect of the health technology assessment. And I think these are very delicate issues, and we have to go into the practical aspect of these. And some of the practical tips have been shared by Dr. Gaurav Jani, Dr. Deepak, and also Dr. Somen and Dr. Komal. So this is going to help us in future refining our targets and the objectives. And also this is one of the workshop which has been conducted first time at AIIMS Jodhpur, but this will lead to another different areas in which we can propose some workshop for the capacity building. As Dr. Shankar has said that most important is the capacity building, because these are the new area which the medical professionals or the health professionals have never been taught about, and which are very important to convince the at the higher stakeholders level about the policies. So there are well-developed guidelines and well-developed centers, like NHS has a nice organization which conduct and carry out the guidelines. Similarly, India has taken a lead. The Department of Health Research has created initially around 8 centers, but now they have included more centers which are in a developing stage. So we are in an infancy stage. We are gradually going to develop, but we also need the important collaboration and the assistance from the state government also. So Dr. Rafiq from state government is also one of the part of our STA, and he is always ready to help and advise some of the areas. He has given many ideas and topics to be carried out. But again, depending on the situation and depending on the need, we can take some of these topics and we can convince the DHR also to execute the health research into these areas. So I thank you all for this listening to these talks where the important stakeholders and the expertise. And also we look forward to see you again tomorrow with some of the more topics which are related to the like experience sharing, and especially the analytical models which we can use in our health technology assessment. So thank you, and over to Dr. Vibha.
Thank you so much, sir. I have posted the feedback form for day 1. Kindly give us the feedback, because it will help to increase. It will help us to make our workshop better, and the next time when we go for the next workshop. Thank you. Thank you, sir.